started. For those who don't know me, I am Mike Devo from International Medical Massage. I've been doing massage for 9 years now, and we have our offices over in the Randallwood subdivision on off of Randall and Dean. My partner Sarah Stanley is at that office as well. And we also have Angela Fedorov from the Sculpted Image joining us tonight. Her business is in Aurora, and her place is much more lavish than International Medical Massage. So tonight we're going to do most of it on chronic low back pain. But before we start that, we're going to talk a little bit about pain. So pain itself is, everyone thinks that pain is bad. It hurts. I don't want pain. But as a clinical therapist, or your doctor or chiropractor, anyone you visit, pain is actually, to us, it's our friend. Because pain is the body's natural alarm system telling you that something is wrong. Something's out of whack or out of kilter. And if we didn't feel pain, you could break a bone or pull something and just walk around and just eventually fall down because you don't realize something's wrong. So what we're trying to do is when you come and see us or any medical person, you do the intake form and they take down your vitals and all the pertinent information, usually a page or two. So what we will do.
So I asked him to turn it off.
Whoa.
What's up?
It is on. You can hear your camera.
Wow, me too. That's good.
All right. Now that we're really awake, I think it's off.
I can still hear it.
Yeah,
I
it's
think-
still on here.
Yeah.
That's all right. You just were testing us. Those who don't pass out are good.
Yeah, we'll have to edit that out. So again, to get back to the pain issue.
You're right. Alright, I asked them twice, I apologize, everyone will get that on
It seems like it's off enough too, so we can.
Give us your full voice, Mike.
Yes, I'll drown it out. All right. So you come into the office and we go through what brings you in. Obviously, some kind of pain situation, and we go from have you been to the doctor? Which doctor? Have you been to the orthopedic? Did they send you off for physical therapy? What medications you're on? All of those are pertinent information. But beyond that, we're going to talk about the pain itself, and initially, when did the pain start? And you might think this is a simple question, but for some people it's not. They're like, well, I don't know, and sometimes they may have just woken up and it just showed up. Or it might have been 2 years ago. So either way, it's important to know when it started so we can roll back when the issue first came on. So that's the first one, the onset of pain. When did it start? Once we get past that, we start looking at the character of pain, or kind of describe what the pain is. So there's 4 basic groups. You've got sharp pain, aching pain, burning pain, or pulsating. Now the sharp pain is a little difficult sometimes to, it's the most difficult to work on because it could be a number of things. It could be a herniated disc, it could be a pulled muscle, it could be joint pain in one of your bones in your elbow or something. So usually that one's going to take a little more time to investigate. Aching pain is typically muscle pain, or something like osteoarthritis. You've got like a knee ache, and people will come in and just say, it just aches, aches all over. Or fibromyalgia is a classic aching pain because you could ache all over or just ache in a certain spot and you just don't know where it's coming from. The burning pain pretty much you can almost 100% guarantee that there's a nerve issue. There's a nerve that's being compromised somewhere along the chain. And there again, we will have to investigate where the pain is coming from, and we will trace back the nerve root coming out of the spine or in the cervix. Somewhere in the spine it's coming, and there's definitely a nerve issue. Pulsating pain would be throbbing, extreme inflammation, possibly a thrombosis, like a blood clot. We're not even touch that. You're going to the doctor. Anything like that, we can't help you. You need to go see the doctor. So then we're going to talk about the type of pain. Is it local? Lots of times, if it is local, it's not necessarily where you think it's coming from. So a good indication or a good example would be if you have a cluster headache and it's like right behind your eyeball. Well, we could work here all day long and not get anywhere. Most likely it's coming from your occipital nerve in the back, and it's going across the top of your head. So it's local, but there's a different route that we need to trace it back to. Then you have radiating pain. So there's two types of radiating pain. A local radiating pain, so it could be just from here to here, or from front to back. But either way, you can trace it back from pretty locally. And then you have your distant radiating pain. Classic example is sciatica. So you have the issue in your piriformis muscle pinching in the back, and it's radiating down the leg. And I have my little handy dermatome guide here. This is a great tool for us as therapists. All the different shaded areas. So the green is for the cervical, the blue is the thoracic, the gray is the lumbar area, and the pink is for the sacral area. So if you come in and say that we talked about the sciatica, I've got pain in my glute, and it's running down my leg, well, you're like L4, L5. That's a classic for us. And then you can see, if you look L4, L5, it's on the back, and then it traces around to the front of the leg. So already we have a map to work on about where the pain is coming from.
You want to pass that around?
What?
You want to pass that around?
Oh, sure. So the radiating pain, a lot of people think of it as referred pain. So they're actually two different things. Radiating pain, like we talked about, has a point from A to B that the pain runs the whole gamut. The referred pain is where the issue, you might feel an issue, but the trigger is coming from somewhere else. You may have chronic gastritis, but it's actually showing up in your back, causing back pain. So that would be referred pain. I also didn't mention when I was talking about the local and distant radiation, there's also spreading pain, and that's another fibromyalgia thing. It feels like it's spreading from one area to the next. other that last would be internal pain or visceral pain. And again, we're going to send you to the doctor for that. So massage just plays a supportive role. So if you have kidney stones or irritable bowel syndrome, you're going to go to the doctor, but you can come for massage therapy after things have cleared up because you probably still have really tight abdominal muscles from the trauma of that issue. So after that, we're going to ask about the time of the pain. When do you feel the pain? Did you get a full night's sleep? Do you feel rested? And when you get up in the morning, and this happens to a lot of us, it doesn't have to be chronic pain, but typical aches and pains. I mean, any of us who are getting older get up in the morning and it's like, oh, you know, I got to stretch and my back and my leg. And so that's really just muscle pain. And while we're sleeping, your heart is not pumping as much, so you're not getting as much blood flow. And when your body's at rest, your muscles are at rest, and your muscles tend to shorten while you're resting. Classic example is plantar fasciitis. As we're resting, the fascia in that foot shortens up, and when you get up in the morning, you're like, oh my God, there's like a rock on the bottom of my foot. But as you walk during the day, it gets better. And once you get the motor going and the blood flowing, things are better. So that's typically a muscle issue. As the day progresses and you're feeling good initially, and you start feeling pain, whatever your job is or what your day consists of, if you're standing too much or sitting at a desk and your neck starts to get painful and it just progresses worse and worse, that's probably more of a disc issue, whether it's in your neck or in your back. And if it gets progressively worse towards the end of the day, but not really bad, it's probably not a bad situation. But if it's like your first hour of the day, whether you're at your desk or standing and you're like in pain already, then it's probably a more serious disc issue. And then late evening or overnight, if you're getting pain during the night, you can't sleep, you're tossing and turning, it could be internal pain, but if it's an issue where you're like have a leg that's numb or tingling or burning, and you're taking Advil and Aleve right before you go to bed, and it's not doing anything at all, it's more than likely, again, a nerve issue. And so that's something, a typical question when we go through this interview process and I'm not sleeping and the Advil's not working, then it's most likely we're looking at a nerve that's compromised. Next, we will talk about the movement. What causes the pain? Is it you're at a computer and it's your neck when you can't turn your neck, or do you do repetitive motion at your job, whether it's sweeping or driving or whatever that repetitive motion is? We're going to go through all those range of motions, whether it's your arm, neck, or your legs. There's certain tests for everything. So if someone comes in with rotator cuff, say, there's testing for each one of the 4 muscles involved in movement of that shoulder. Case in point, one of my clients brought her daughter in and she was diagnosed with frozen shoulder. And this happens a lot. You go to the doctor and you can't move your arm and it's frozen shoulder. So that's kind of what they send you out with. So I said, okay, we'll do the testing. So we went through each each test and range of motion. I'm like, raise your arm, she's like this. I'm like, well, I think we can eliminate frozen shoulder because she's like this. But she couldn't, like, for one motion. So it ended up being like bicep tendonitis, but it wasn't frozen shoulder. And that's a totally different protocol I'm going to use, we're going to use for bicep tendonitis than frozen shoulder. So all of these things make a big difference on how we're going to attack the situation. And next is the intensity, 1 to 10. You've all seen whether you go to the dentist, you know, it's either the smiley face or the big frown or somewhere in between. So we're going to ask you kind of where you're at, and after each session, when you come in, it's like, where are you at, 1 to 10? Are we doing better? Are we worse? Where are we at? So we always have to ask that to kind of chart what progress we're making. Then lastly is talking about sensory or motor testing. So we talked about the sciatic issue, and a lot of times I'll ask people, well, where is the numbness and tingling? I don't know. You know, it's the whole leg. You know, and if you see that chart going around, there's some areas where it's just a fine line, where it could be your little toe, and next to it, it's the sacral area and not the other area. So it makes a big difference. So we'll do like little, just like sensory testing, like on either leg or foot or arm, just to see where the breakdown is. And even on a thigh, the outside of the thigh could be fine. The inside of the thigh, it's like, I don't feel anything. So every spot that you work on makes a big difference. So all of those, it sounds like a lot, and it's like, just get me on the table, you know, stop asking me all these questions. But it's really important to ask those questions, because we could save 2 or 3 hourly sessions by asking all those questions and just narrowing it down to what the issue really is. And it's saving you time, me time, and aggravation, and it just makes things a lot easier. So say a dental hygienist comes in to the office and they say, my neck is killing me, my shoulders are killing me, and oh, by the way, I think I have carpal tunnel. Well, we're going to go through all these questions and eventually find out that, oh, by the way, they can't sleep, they're waking up at night, it's getting worse, and it's not just the carpal tunnel, I'm kind of feeling it in my whole arm and neck. Well, now we've just changed the picture that it could possibly be what's called thoracic outlet syndrome. So there's a pinched nerve in the neck, it's coming from the neck, which is pinching the brachial plexus, which is causing the whole issue down the arm. And again, now we've just formulated a plan, and we can work with that plan, and we'll go over, say, I think this is what it is, and this is going to happen. And hopefully that happens, and we're on the right track. If not, we'll know in 1 or 2 sessions that something's wrong, or sometimes we go through this whole interview process, and like through the second section, it's like, oh, well, it was worse after I had my car accident. So I'm like, you didn't tell me you had a car accident. So you just get a curve sometimes, and you have to work with those curves. So, but it's just really important. So I just wanted to go through that. It's just good general information. So when you think about when you're having your pain, and then you know yourself, oh, it's okay. It's probably just muscle pain. All right. Any questions about any of that? I know I'm zipping through it pretty quickly. All right, great. So we're going to get right into the low back issue. There's a couple of terms that you don't hear anymore. Lumbago is like an old back pain term, and lumbalgia. Lumbalgia is just kind of a overall term for chronic back pain, usually involving disc herniation, including nerve issues. So when we look at lumbalgia, one of the main, or two of the main, can you put up the picture on that? There we go. So we look at this picture, the little, if you imagine that we're all dinosaurs on the inside and we have that little wings on the back, the fancy name is pars interarticularis, but it's also known as the spinous process. So many of you have probably heard of spondylosis. It's a common term. So you can see there's a little fracture in that spinous process there. Thank you. That's pretty fancy.
Hey, modern times.
So if left unattended and it gets worse, then it turns into spondylolisthesis. And if you can see on the back there, it's like totally broken off, and you can also see where that disc is getting squeezed in the back. And the worse it gets, the more that disc gets squeezed, and then at times it'll rupture. And it's not on that picture, but when it ruptures, now it's out in the nerves and all hell's broken loose. So the five major causes of lumbalgia are lumbosacral spondylosis, trauma or chronic overload, sacroiliitis, which is inflammation of the sacral joint, chronic visceral disorders, internal order disorders, and fibromyalgia. So for today's purposes, we're going to focus on sacroiliitis, which I can never say, and the back pain due to the quadratus lumborum. So this is the QL, quadratus lumborum. This is really a tricky muscle, and you can see there's a lot going on here. So the quad, obviously, there's four sides to it, and it's attached on the spine, on the ribs, and on the hip bone there. So any one of those issues with the ribs or the spine or the hips can throw that muscle out of whack. So this is one of the muscles that assists us for standing. Animals don't have QL like humans do. If they do, it's in a really minor position. So this is like you're bending and twisting, shoveling, golfing, baseball, just sweeping, just about any kind of movement like that you can imagine. And if you've ever had pain there, it really feels like there's a stick in your back or something poking you, because it also mimics like disc herniation pain as well. So it can be really painful. I lost my associate over there, but the other group is the erector spinae. Sarah, can you come over?
Yep.
So we'll do this live.
Yay!
All right. Sarah's much better looking from the front, but we're going to use her back. Oh, there. Thank you. So the erector spinae, you can see there's like three different groups on each side running down. The longissimus, thank you. And they're running all the way down into your gluteal fascia here. And they insert in different areas along the spine. So I'm going to have Sarah just bend down. And now when she bends back up and straightens up, those erectors are stretching and assisting to pull her back up. So between that and the QL muscle, a lot of these are your standing supporting muscles. And the other one that we were talking about is the iliopsoas. That's on the front of the QL, on the front of the spine. And Sarah will talk some more about that. So we're going to get Sarah on the table here, on your back. So the first thing we're going to do is we're going to do some testing for the SI joint. So the first test is going to be, I'm going to apply some pressure equally.
Good job, Sarah.
And sometimes you'll hear them say that even louder. And it typically would be on one side or the other. All right. We're going to have you turn on your side facing the audience. I'm going to put this under your tummy. Okay? So we're going to do each side one at a time, and we're going to do the same thing. We're going to put pressure on that hip. So if there's any inflammation in that SI joint, it's going to show up with me applying pressure here.
You'd feel it.
Yeah, you'd feel it. Okay, on your back, please. The last test is called Gates test, and this is just a simple leg raise. And again, we might have she might have glute pain or some other pain, but we're just looking for the SI pain right here with this test. All right, great. So we're gonna start with, Lori, can you put on the video? Yeah. So I have a corresponding video that we're gonna run through, and I'll try and keep up with it. It's basically to show the steps that I'm doing, because I know it's hard for everybody to see what I'm doing on Sarah. So we're trying to tell me?
You want a sound on it?
No.
I don't think there is any sound, is
No.
Oh my God, your hands are cold.
it? Cold hands. My favorite part. Warm heart. It's not part of it. Typical
It's
therapist.
not? Well, so she gets that right. You might have to close it out and go back in, Lori. Anyway, so we'll start anyway. So basically, yeah.
That's a nice one.
All right. All right. So initially, we're just warming up.
Warming up the hands, right?
Yeah, warming up the hands. So we're following the stroke. You'll notice I'm not just going here. I'm going all the way up to the top. So every time we're following a stroke, we want to bring the area to the nearest lymph nodes. So we're warming everything up, but we're also draining any extra swelling or fluid as well. And after that, we start working on these erector spinae muscles. This is kind of just working that whole group and stretching them out. And there's different variations I can use. You can use my knuckles, it's stretching that whole, all three of those at the same time. And if I want to do a localized spot and work, I can just use one hand and do a local. Trying to slap everybody's way. I know. So as you can see, that's what I'm doing. Like draw the skin back and you stay in the groove between the erector spinae and the spinal groove. So you're moving that whole group out. I know, it's not going to fit either. So here, we talked about those spinous processes coming out of your spine. We're doing like friction on each one.
Which is not pleasant most of the time.
Let it out, Sarah.
But it's doing its job. We wanna get into this area.
You can feel while he's doing it, when the friction, when it's uncomfortable, it releases. The muscle gives in. Because what he's doing is he's stimulating the little organs around the muscles to shut down by applying that friction.
And it's just running through, these are different types of friction. So there's all of these various methods of effleurage, the gliding, the kneading, the friction, all of them serve a purpose, and they're all done in a sequence for a reason. Because thanks to Dr. Ross at the Science and Massage Institute for putting these videos together, all of these methods are from Russia, Eastern Europe, and around the world, and they're all been researched and proven effective. So now we're moving to the low, I'm already at the low back, but we did the mid back, and we're gonna do the same thing down here. Now we're working on those lumbar erectors. This is showing we're working along the outer edge of those erectors, and then along the medial edge. All of this is meant to lengthen all of these erectors that are just pulling the back tighter, pulling the vertebrae tighter. We can't loosen anything else up before we get to these, until we get these loose. This is a vibration tool. I'm not turning it on because it's really loud, but again, it's just another technique like the friction, like the kneading, but the vibration acts as kind of a, if any of you have been to a chiropractor and had electric stim, it kind of has the same effect. It's a very high RPM, vibrating and breaking up the muscle tissue. We did the spinous process friction in the thoracic back. Now we're down doing it on the lumbar spinous process. this is a different way to get at those erector spinae from a different angle. Now we're kind of like raising them from underneath along the whole length. That line he's showing here is the crest of your hip bone. So to find landmarks, you're going to find the top of her hip bone, come across diagonally, and that's where her L4, it's actually where anybody's is. So whoever is sitting here and you've got the top of your iliac crest, across from that is going to be your L4. And so below that is going to be your L5. And then they're working the tendons right next to that L5. And we also call this the box. There's like, you're getting into that SI joint. And there's doing different forms of friction in there as well. The reason you're doing friction is to bring healing inflammation. Everybody thinks inflammation is bad, and typically it is, but when you're doing friction for massage purposes, whether it's on a joint or on a bone, you're bringing healing inflammation to that area. Doing more out towards the glutes here. So all of these are designed for that SI joint.
So if you had this done, what pain, where's the pain that you're treating?
It could be any level. And just for instance, I had someone a couple weeks ago who had this very issue, and he fell and had so much pain he couldn't lay like this. So we had to work on his side and work on that until it calmed down. And then the next time he came in, he was able to lay on his side, and then we could work a little deeper.
So would it be leg pain or back pain to get here?
If you could get back pain, and it will cause leg pain as well if it's referring down into your leg. So now I've lost my spot, but so we're gonna work in this QL, and you will see it come up. The other good thing about using the electric massager is for trigger point work. So if we find that we have a trigger point in that QL muscle that we were showing, we'll use the electric massager on that trigger point for about a minute or two, and it causes the nerve to overload, and essentially it anesthetizes the area. So I can go in here for a minute or two, release that, and then I can go in and work the trigger point with my hand and release that area, and she won't feel that pain, because if I were to just go in there and just dig right in, she wouldn't allow, it wouldn't allow me to get in deeper, so that's the issue. And getting that QL muscle itself, I'm kind of like hooking my thumbs to get in there, and you saw that area where it attached to the ribs, so you have to work that third, the upper third on a particular angle, the middle third like straight on, and the bottom third that's attached to that hip on a different angle to make sure you're getting that full muscle. All right, let's have you turn over on your back. I'll do some stretches here. So these are just some passive stretches. I'm going to ask you to breathe. And then we're just going to do a long stretch.
Is that stretching out those muscles you were just working?
Yes. Breathe. Good. Now there's a different variation. They're going to continue on with other different massage techniques. There's a different variation of this stretch. A lot of times people will come in and say, my hip's out of joint. I know it's out. My leg is longer than the other. And it's true. Sometimes they are. So we do like a test where I'm holding on to her, what's the malleola bone, and to see if they're equal or not. And a lot of times, they'll be like an inch off. So we're going to pretend that her left leg is an inch shorter than the right. So we're going to do a little traction. I'm going to ask you to breathe again. Let it out. So while I'm pulling, I'm resisting the other leg, and we're straightening out that hip. She's going to think it's a miracle, but it's not.
Especially.
So, I forgot my sheet, so we're going to use my trusty scarf here to do another stretch. So this is called post-isometric release stretching. So essentially, we're working both sides on the muscle against each other in order to get it to relax. So we're going to do this on 3 different levels. So I'm going to ask Sarah to breathe, let it out, and then we're going to stretch. So on the first level, I'm going to ask her to resist me about 20% of her strength. Go ahead, resist. It's only 5%. And then I would tell her to relax. Breathe again. And now we will stretch. And we will stretch 2 more times. And then we will do resisted at 2 more different levels. Each time, that is going to relax those muscles in the back and lengthen for us. It's really a good stretch.
The scarf worked well.
What's that?
The scarf worked well, right?
Yeah. So they're showing more trigger point work and connective tissue massage. When they show the connective tissue massage, we would probably use cup or cupping because it's really just, I think we both find it more effective than just hand connective tissue massage. And it's quick and, well, Sarah loves it more than I do. She's got all kinds of different cups. All right, Laura, you can cut And that's essentially working on the SI joint and the QL. I mean, again, I went through it pretty quickly. There's a lot that goes into it, but from start to finish, like I said, the most important thing is the evaluation, because that's like 50% of the problem. When we know what the problem is, I'm not gonna see the rest as easy, but it is easier for sure. The hardest part is figuring out usually where the problem is. That's it. Any questions?
So do you have to be referred to you by a doctor, or how does it work?
No, we do not.
Phone number.
Yeah, yes. A lot of times we do get referrals for, Sarah and I both worked at Delmore Health and Wellness for a while, so we have a relationship with the physical therapist over there, and they will send us clients who are either they're done with their PT and they still need more work, or they're not too sure what to do with them. There's always mysterious back pain, and that's kind of what we
Specialize in.
yes. we
Well
like the
said.
weird stuff, because a lot of times people haven't been able to get help anywhere else, and they're just looking for some help, and hopefully we can offer that.